Where is the photo?
Assalamu alaikum. The short clinical station day. First scenario, you will examine Mr. John Smith, 45 years. Please examine his abdomen. Okay. Dr. Sarah, you will start now.
Yes. Okay.
Oh.
Hello,
Hi, hello.
I'm Dr. Awad Kareem. I'm one of the candidates for exam today. Yes, I would like to examine you during our examination. If you feel any pain or discomfort, please let me know. Is that okay?
Sure, doctor.
Okay, so I will wash my hand. Please, Mr. Smith, could you please expose your tummy for me?
Okay, my tummy is exposed.
Yeah, I will look for surrounding. If there is any significance.
Nothing.
Okay, I'm start examination by examining the hand of the patients. If there's any sign, yes, clubbing, lychonychia,
None.
colionychia.
None.
Okay. Please, could you please turn your both hand for me? I will check if
Okay.
there's any palmar erythema, pituitary contraction.
No.
Okay.
None.
Yeah, okay. Could you spread your both hand for me, please? I will check
Okay.
if there's any clubbing tremor.
No problem, tremor.
Okay. After that, I'm going to expose and to inspect both arms of the patient if there is any fistula.
No fistula.
Okay. Okay. No fistula. Okay. After that, I'm going. Yes. After that, I'm going to examine the eye if there's any pillar in jaundice.
Yes, pallor, but no jaundice.
There's jaundice.
No jaundice, but it's pale.
Bell. Okay. Okay. In the face, if there's any parotid enlargement, waist
No.
temporalis muscle.
No.
Okay. Please, could you, yes, open your mouth for me.
Okay, I've opened my mouth.
Yes, there is mouth ulcer. Okay.
Yep.
Okay. I'm going to check if there is any gingival hyperplasia.
No.
Okay. After that, I'm going to check for the JVB. Please, could you please turn your head for me?
JVP, not
JVB.
wrist, not wrist.
Okay. I will check for hepatocytic reflex also.
No
Okay.
JVP.
Okay. Okay. Also, I would like to inspect the chest if there is any gynecomastia, spider nevi, and the hair in the axillary. Scanty hair or not?
None.
Okay. So after that, I'm going to inspect the abdomen. Yes, there is a scar, which is the laboratory scar, and two scar small. Okay. Okay. So if there is any other things in the abdomen, yeah.
Any other what?
Okay. There is a multiple scar. Okay. Okay. So after that, I'm going to from the end of the bed, I will ask the Mr. Smith. Could you please give me a cuff? If there is any superficial masses or hernia.
No.
Okay, I will warm my hands. I will start. Mr. Smith, do you have any pain in your tummy now?
No, no pain.
Okay, I'm going to check by superficial palpation if there is any tenderness or superficial masses.
No tenderness, no masses.
Okay, so I will start to check for by deep palpation for the liver.
Okay.
If there is any liver enlargement.
No liver enlargement.
The liver is fine.
Liver is fine. No liver enlargement.
What?
No liver enlargement.
Okay, okay. Also I'm going to check for the spleen.
Spleen on not enlarged.
Not enlarged also.
No, no.
Okay, I will turn the patient in the yes in the right side. I will confirm that I will do also percussions and I will start palpation from the left iliac fossa up to the left hypochondrial, upper left hypochondrial. No spleen.
No spleen.
Okay. So after that, I'm going to check the kidney.
Mm.
If there's any palatable kidney.
No.
Okay. I'm going to percuss if there's any ascites by shifting dullness.
No ascites.
Mm-hmm. I'm
No
going to
ascites.
Okay. So I'm going to auscultate, yes, if there's any renal pruy,
No renal pruy.
venous hum,
No.
bowel sound.
Bowel sound is hyperactive.
Okay. So please, Mr. Smith, could you please sit for me? I would like to examine the lymph node for this patient,
Okay. No lymph node
including
enlargement.
Virchow lymph node.
No lymph node enlargement.
Okay. I will check for sacral edema from the back of the patients and any bipedic crepitations.
No.
And lower limb edema.
No.
In his lower. No. Okay. Okay.
1 minute
So.
left.
Okay. Yes. Okay. Also, I would like to check the eye if there's any redness in the eye.
No.
Okay. I would like to complete my examination by examining the genital area if there's any ulcer also.
All right. Assume done.
What?
Assume done. Normal.
Normal. Okay.
Yeah.
Yeah. Okay.
Okay. What you would like to offer?
Yes.
10 seconds remains. 8, 7,
Yes.
6.
Also, I need a full set of vital charts for this patient. And yes.
Okay. Time is up.
No facial appearance thalassaemic patients.
Okay. Examiner question, Dr. Ayula, please.
All right. Can you summarize the patient, please? The findings.
Yeah, okay. Yes, I examine Mr. John Smith, 45 years. Yes. On examination of this patient, yes, he has pillar. Okay, an examination, and he has mouth ulcer. Okay, and on examination of his abdomen, he has multiple scars. One of these scars is midline sternum scar, and also there is the small scars below it, below the umbilical, and also there is the transverse scars, mainly in the left middle abdomen. Okay. Apart from that, I could not appreciate any hepatomegaly or splenomegaly. No ascites also.
Okay, all right. So what are your possible differentials? What is the diagnosis?
Yes, this patients, yes, this patient, it might has myeloproliferative disorders. Also chronic hemolytic anemia. I think this scar, it might be due to splenectomy scar.
Okay.
Because now this patient is pillar also. No feature of thalassemia in this patient. Okay, sad.
All right. So how will you investigate?
Yes, regarding the investigations for this patient, I will do the general workup in the form of full blood count to look for low hemoglobin count with peripheral blood film also. If there's any target cell or any any target cell, and also I will do renal function tests with electrolyte, liver function tests. I will do investigations to confirm our diagnosis. I will do for this patient's abdominal ultrasound. Okay.
Okay.
Yes. I will do hemolytic.
Thank you, Doctor.
Yes, thalassemia screen and also
Thank you, Dr. Sarah. What do
bone
you?
marrow biopsy. Yes.
Yeah, during the examination, did you pick any? What was the bowel sound of this patient like?
What?
The bowel sound of this patient. What is it like? Is there any significance to that?
Yes, if the patient has intestinal obstruction, it might be, or any cancer.
I mean, what was
Might
the
be
bowel sound
exaggerated.
of this patient?
Bowel sound?
Yes.
You tell me the bowel sound normal.
No, but okay. If that was not what
Audible.
I said hyperactive bowel sound.
Okay, I didn't hear you well.
Okay.
Okay. So
if
indicate,
you have picked that, would that be anything you will have considered aside
yes,
from the differentials you've given?
yes, bowel cancer and also obstruction, intestinal obstruction.
Okay. So do you want to consider how you investigate this patient?
Yes, also I will do X-ray abdomen and CT abdomen with contrast and okay.
Okay. So what other differentials will you have considered?
Yes, I will do bone marrow biopsy and also thalassemia screening genetic test.
Okay. I mean, in terms of the diagnosis, is there any other diagnosis you will have considered putting the mouth ulcer, the scar, the anemia, and the hyperactive bowel sound that you picked? Is there any other diagnosis you will have considered?
Yes, malignancy, cancer.
Okay, all right. I'm in a meeting, please. Okay, sorry about that. So, how will you manage the patients?
Yes, regarding the management, first non-pharmacological education and counseling about his conditions, NDT. Yes, gastroenterologist and hematologist according to his conditions, and even surgical. Yes. So I will treat the underlying cause for his conditions.
Okay, all right. Thank you.
Okay, thank you, Dr.
Okay,
Ayla.
thank you.
Yeah. Okay, can you comment now, please? Then I will.
Okay, all right. Well done, Dr. Sarah. It was a good presentation, good skills in identifying signs. Even the examination skills was thorough. Examination, yes, was thorough, and every other thing. And looking at this patient, the multiple scar that he has, the ulcer in the mouth, the pallor, and the bowel sound. Putting all of this together, if you want to have a second thought, will you have consider an inflammatory bowel disease in this
bowel
patient?
disease, yes, Crohn's, yeah. Yes.
You'll have considered it in this patient. Yes, they have possibly have had surgery, post-surgery surgery for previous complications, and now coming down with exacerbation, another exacerbation now. The scar is a midline scar, also has a stomach scar, stomach side scar, a previous stomach side scar. So it would have possibly be a patient with multiple abdominal scar. Possibly putting all the signs together, I would think this patient would have an inflammatory bowel disease with previous surgery for possible complications of inflammatory bowel disease. Other differential would then include bowel cancer that has an obstruction due to a bowel cancer, possibly. Then we can now possibly think of other causes of active bowel in this patient. It could be any other thing in this patient, but the top diagnosis will have been the inflammatory bowel disease with previous complication that had surgery. Then bowel cancer, celiac disease, maybe malabsorption, and all other things sort of in that line. But possibly this patient could have been an inflammatory bowel disease, and then would have gone in that management. I think is it. I think it's the scar, the anemia, the ulcer in the mouth, and then the bowel sound move towards that diagnosis. All right.
Yes.
Yeah. Does it? Okay.
Yeah, thank you, Dr. Ayala. Well done. Good case. So the finding will give you 3 or maybe less differential diagnosis based on the ulcer, mouth ulcer, scar in the tummy, and the pallor. So what you could add to the examination, Dr. Sarah, if you want to add, you will offer.
Yes, regarding the eye, I check for the redness and also the joint if there's any arthritis in the joint.
Yeah, this is extra articular, you mean,
Yes,
manifestation.
extraintestinal, yes, manifestation.
Yeah, extraintestinal, okay. What else in the
And the
tummy?
back also. In the tummy?
Yeah, you will offer, but you cannot do, or you will not do it.
Yes, rectal examination.
Exactly,
You
yes,
mean?
digital rectal examination. Looking for any blood.
Yeah.
Yeah, okay. As well as
Any
inguinal lymph node.
fistula, yes.
Yeah, okay. I think as examination wise, you were perfect. You did the all steps possible to be done in this patient. So let's talk about inflammatory bowel disease. What particularly you will mention? Crohn's or ulcerative?
Crohn's, because of this patient, he has mouth ulcer.
Exactly, yes. So we'll talk about differential of mouth ulcer. What are the differential diagnosis of mouth ulcer in cases? He will ask
Crohn's
you.
first, yes, and Bessy disease,
Okay,
and also some SLE, systemic lupus, sometimes.
okay.
Yes,
Celiac
yes, celiac also. Okay.
and HIV.
Uh, yes, HIV. Okay.
Okay. That's why you offer
Sometimes could be fungal. Okay.
sorry,
Fungal and abscess
fungal
ulcers.
infection. Okay,
Mm.
okay. You offer the genital examination to rule out PASIT.
Yes.
Yeah, okay, good to think about. Let's talk about Crohn's itself. What's the
Mm.
complication? What the complication you know about Crohn's disease? Intestinal first,
Complex.
then extra-intestinal.
Yes. Um, intestinal fistulating Crohn's and
Mm.
also intestinal obstruction and adhesion.
Mm-hmm.
Malabsorptive symptom or
Mm-hmm.
complications. Okay. And extra-intestinal
Still in the Crohn's,
features.
you mentioned fistula.
Visual, yes.
Yeah, very important one. Yes.
Abscess also.
Yeah.
Abscess,
Okay.
perianal abscess.
Okay.
Okay, and a risk of cancer also, but
Not common
and
as ulcerative.
ulcerative colitis, yes.
One more. You mentioned the
Uh,
medical part, the surgical part.
surgical burst, toxic megacolon, but more in the ulcerative colitis. Cancer.
Short bowel syndrome, is it?
Okay, short bowel, yes, short bowel
Yeah.
syndrome,
And malabsorption as well. Okay.
yes.
These are the intestinal, the extra-intestinal.
Extraintestinal, yes, skin rash like pyodermatodrosum, erythema nodosum, and also the eye manifestations like anterior uveitis, scleritis, okay, and joint also arthritis, peripheral arthritis, and sacroiliitis as general.
Yeah, articular.
And yes, malabsorptive also, vitamin deficiency.
Okay. What the specific vitamins or particular vitamin deficiency will be there?
Fat soluble vitamins.
What the names?
Vitamin D, A, okay, E.
And
Iron and folate also.
vitamin A and D, E and K.
Yes.
Okay. Other supplement or other yes, mineral deficiency in the form of folate or
Iron, B12,
iron.
other causes of anemia, yes.
Okay. So the surgery, you speak about laparotomy in this patient, and Dr. Ayola added to them the ileostomy, right?
Ileostomy scar, like she said.
Yeah. Any surgery can be done for this patient? Other surgery?
Yes, apart from obstruction, fistula. You mean other surgery apart from laparotomy scar or colostomy?
Yes.
I didn't sure.
Fistula, for example, resection. If it is
Yes, fistula, yes.
Vasectomy, I think it's the name. I'm not sure about the name. Okay. Pouch, you know about pouch? It's like a diversion if the colon is affected. Pouch formation. Okay. I think this is the topic. The investigation, yes, you mentioned already the antibodies, specific investigation for Crohn's.
Yes, for Crohn's. Yes, for Crohn's, antibody, yes. And also I will do fecal calprotectin. Okay. Also, yes, I will do upper GI endoscopy and colonoscopy if need endoscopy.
Yeah, definitely one of the investigation.
Yes.
Okay, you didn't mention the specific antibiotic.
Apart from the general.
Antibodies, sorry, the specific antibody.
A specific antibody, I didn't remember the name.
ASCA, Saccharomyces.
ASCA, yes. Saccharomyces antibody.
Cervase antibody, okay. P-ANCA as well, one of the possible. P-ANCA. Okay, for the inflammatory bowel, the ulcerative colitis, what is the antibodies, specific antibodies?
I think association with HALA B27, HLA 27, just specific antibody, I didn't remember.
C-ANCA. Okay.
Okay, C-ANCA.
Ulcerative colitis, there is C, but the antibodies P-ANCA. Here, C-ANCA.
B-ANCA in Crohn's?
P-ANCA in Crohn's. Sorry, the opposite. P-ANCA in Crohn's, yes, and C-ANCA in the ulcerative colitis. Okay.
Okay.
C for C. What else we can add here? Okay, the management plan, how to treat the patient generally?
Yes, generally supportive treatment. If a patient need rehydrations, electrolyte corrections, and non-pharmacological education counseling about his condition, MDT, including dietitian, and also vitamin replacement. For the mesalazine, oral or rectal, okay, and
So you
immunosuppressant
have to
like
specify acute
azathioprine.
or chronic.
Yes.
And the part also affected. Is it rectal
Yes.
or
Yes,
colon?
induction or maintenance. Yes, induction or maintenance. According to the patient's steroids, sometimes amino salicylate also, like mesalazine, and steroid also. Okay, and biological. Regarding the maintenance, I will give
What's
him
biological, you know? What biological option?
anti-TNF, like
Infliximab.
infliximab. Yes.
Okay.
For maintenance, immunosuppressant like azathioprine, okay, and also methotrexate, and biological also, and
Okay.
surgical option also. If there is any obstruction, any fistula, any abscess, any stricture.
Okay. Any cure for Crohn's disease?
Cure? No, not curable, but controllable.
And what about ulcerative colitis? Any cure?
I think also all of them controllable.
No,
Not
ulcerative
curable.
colitis, it's curable with total colectomy, right? Because it
Okay,
affects
surgery.
the colon only. Yeah, surgical, yes, surgical option. Okay, by the
Okay.
way, P-ANCA for ulcerative and ASCA for Crohn's. I mix. Okay, P for ulcerative, not C. P-ANCA for
Okay.
ulcerative colitis and ASCA for Crohn's. Okay, the last question. The surgical option, yes, you mentioned. The medical option you mentioned. For the flare-up, if the patient admitted with severe diarrhea and frequent diarrhea as a Crohn's flare-up, what's the
Yes.
option? The medical
Option for
option, the pharmacological option, yes.
hydrocortisone.
Yes, exactly.
IV.
So steroid, yes.
Yes.
Okay. What possible cause of anemia in Crohn's?
Anemia of chronic disease, and also iron deficiency anemia and macrocytic anemia also due to vitamin B12 folate deficiency.
Okay. Yeah, fair
Microcytic
enough.
anemia. Yes.
Yeah, fair enough. Thank you. Dr.
Thank you.
Ayula, you want to add any question or comment? Any question? Yeah.
No, thank you.
Okay, any question, Dr. Sarah, or you want to ask anything? Any doubt? You want to ask Dr. Ayula
No,
about the
thank you.
case?
No, thank you. Thank you.
Okay. Total collective,
Yes,
yes.
just for this scar. Yes, this scar.
Yeah, the
Could you
scar,
explain for me? Yes,
Dr.
for this.
Ayula, can you explain the case?
Yes.
Okay, this is a case of a patient who has had an obstruction, previous of colectomy with colostomy, cholecystectomy with colostomy in the past due to obstruction from Crohn's disease. Okay, as you can see, it has a midline laparoscopy scar with a stoma scar. So from looking at this patient in totality, what is prominent is that he has had a surgery, previous bowel surgery, because of the location of this scar. Is anemic. He has this aphthous ulcer, which is commonly found in Crohn's disease. Okay, and then the the bowel sounds, okay, for him as well. Possibly might be having some acute exacerbation now of his Crohn's disease. But however, in Crohn's is common in the iliac area, so we expect that the stomach sac will be possibly be in the iliac area. But of course, we know that Crohn's can occur in any part of the colon, but it's just common in the ileum region, in the left iliac fossa. Okay, so that was the mind behind this station, to remind ourselves about the possible complication that can come up from inflammatory bowel disease, which could include bowel obstruction, fistula. Well, abscess is common now with ulcerative colitis, toxic megacolon, also common with ulcerative colitis. These are just the possible surgical indication in patients with inflammatory bowel disease. So the mind was just to remind ourselves about inflammatory bowel disease, then possibly look at how to differentiate between Crohn's disease and inflammatory bowel disease. Look out for the extra intestinal features of inflammatory bowel disease, which you have earlier highlighted, and that would include the uveitis, conjunctivitis, they can also have episcleritis, which can be seen as redness of the eyes in examination. They can also be jaundice as well, because they are prone to have gallstone. Also, because of the primary sclerosis cirrhosis that can happen with ulcerative colitis, they can also be jaundice. They can have some skin manifestation like erythema nodosum in the legs. Pyoderma gangrenosum as well can also be found in them. Okay, so, and what else? I was just again how to differentiate between the two, the Crohn's disease and the ulcerative colitis clinically. Of course, we know that aphthous ulcer is common in Crohn's, not as common in certainly not found in ulcerative colitis. Ulcerative colitis is usually restricted to the colon, more at the sigmoid rectum axis, where Crohn's can occur span all through from the mouth to the anus. Fistula is also common with the Crohn's disease, okay, while abscess is common with ulcerative colitis. Then colonoscopy wise, colonoscopy, when you do a colonoscopy, skip lesion is common is found in ulcerative in Crohn's disease, the cobblestone appearance with Crohn's disease. The ulcerative colitis is usually superficial, and of course you will see some abscess. And when you do your histology, the possible differences that can be seen in histology, of course, it spans through all the transmural for Crohn's disease. So, and management wise, of course, that acute management, when they have the acute exacerbation of this, and in mild, moderate, and severe, especially if it is Crohn's disease, ulcerative colitis, I mean to say, in terms of the number of times, the episode of diarrhea that they have, if there's fever, okay, episode of diarrhea, if it's less than, I think 4 is mild, 4 to 6 is moderate, above 6 it's severe, and that will also influence the management. That will also influence the management in the patients, and that would inform decision to use possibly a rectal mesalazine, or use an oral steroid, or even IV steroid admission if it is severe in ulcerative colitis, while in Crohn's disease, of course, in Crohn's disease, I think it's more, it's more of steroid that we use in the acute phase in Crohn's disease. You can also use the sulfasalazines as well in acute phase of Crohn's disease. So basically, that was just the mind behind this, behind the question. Just remind ourselves about it. Well
Yes.
done.
Yeah, thank you, Dr. Ayola. So the colonoscopy finding is very important. Skip lesion with the ulcerative colitis. And for Crohn's, you might have the, I think you mentioned goblet cell in the histopathology, right?
Hmm.
But transmural affection of the mucosa with the Crohn's disease. The also other manifestation, the ulcerative colitis, skip lesion. We mentioned skip lesion, right? And yes, the part of the colon, mostly the distal part in the ulcerative colitis, while in the Crohn's, maybe the whole bowel, commonly the ileum or the ileocecal part. The ileostomy will be mostly associated with Crohn's disease, and colostomy possibly with the ulcerative colitis. Okay. Yeah, whenever you have rectal affection, consider adding rectal mesalazine. The last question, Dr. Sarah, what is the most common complication of mesalazine? Dr. Sarah,
Yes, yes.
what is the most common complication of mesalazine?
Pancreatitis?
Yes. Okay. Any other question? Anyone
No,
want to
thank
add?
you.
Anyone want to add question or suggestion? Okay, so we'll move to the next scenario. Dr. Ayola, you ready? Can unmute yourself. Cryptabscess, yes. Cryptabscess and ulcerative colitis, yes.
Yes, I'm ready.
Cryptabscess.
Yes, I'm ready.
Cryptabscess and ulcerative colitis. And for the cobblestone for the Crohn's. Okay, this is the finding in colonoscopy. Blood in stool is common in ulcerative colitis. Yes, this is the commonest bloody diarrhea with the ulcerative colitis. However, it might happen with Crohn's, but it's not common. Okay. What's the case, Dr. Sarah? Okay, Mr. Ali,
Yes.
50 years old, examine his lower limb. Sorry,
دكتور سحر.
yes, I mute here. Okay. Dr. Ayula, your patient, Mr. Ali, examine his lower limb.
Okay.
Here you go.
All right. Hello.
Hello.
My name is Dr. Ayola. I'm one of the doctors here today. Thank you for allowing me to examine you. Okay. Can I confirm you
Okay.
are Mr. Ali, 50 years old?
Yes, doctor.
All right. So today I'll be examining your legs. Okay. I'll be giving you some instruction. I don't expect you to feel any pain, but if you do feel any form of discomfort, do let me know. Okay.
Okay, doctor.
All right. Good. So I will look around the patient. Any walking aids? Okay. Any prosthetics? So I will ask him to expose the leg. Okay. Expose as
Yes,
much
there
as
is
possible.
walking.
So you say what?
There is walking aid.
Okay. All right. All right. So I will expose the leg. All right. And I will observe, look at the legs, any muscle wasting, any
Yes,
fasciculation
there is wasting
on both legs or on both lower limb or just one.
in both
On
legs.
both, okay. Any fasciculation, any
No.
deformity, like
What do you mean?
I'm looking at for any joint deformity, and also is there any flat foot, any eye hack foot?
There's external rotation of the boat.
External
His feet.
rotation of the boat
Yes.
face. Okay, all right, thank you. So I will look. I also check for the tone. So Mr. Ali, I'll be moving your legs now. Okay, just release yourself for me. Let me do it. So I will roll the thigh to check for the hip tone. Then flex the nail as well, both nail. Then check for the tone at the ankle as well. And then how is the tone like? And then I will check
Yes, hypertonia.
hypertonia. Okay, on both sides. Are they equal?
Yes.
All right, thank you. So I also want to check for ankylosing. Is there any form of ankylosing? But
Cronus, yes,
yes,
positive.
this
Yes,
cronus is positive. All right, thank you. So I want to check how strong your legs are, Mr. Hali. So can you lift up your legs for me, please? Both legs. Are you able to lift up your right legs for me?
Yes, he's able.
Okay, all right.
But
So
not
don't let me push your leg down. I'm trying to push your leg down. Can you push it down? And okay, I'm also trying to push your leg against my hand as well. So are you able to fold your leg for me and push your legs against my hand? Can you do that?
Yeah, there's weakness
There's
in the thigh
weakness.
muscle. Yes.
Okay, on both sides. All right, thank you. So I'm checking for other groups of muscle. Are you able to press your fold your leg against my hand? Then I'm checking the one at the foot, both foot. And
Okay,
also press your. Okay, I'm listening.
Before that, the weakness is more in the flexor, more than an extensor.
In the flexor
Okay.
more than the extensor.
Yes.
Yeah. Okay.
Yeah.
Thank you.
The thigh muscle.
So, all right. Thank you. So I'll also go ahead to check for the reflexes. I'm going to use this to tap your joints. So bear with me, Mr. Ali. So I'll start from the hip, from the knee joint. Okay. How is the reflexes are?
Hyperreflexia.
Hyperreflexia. All right, thank you. So I'll go ahead to check for. I'm going to use this to tickle your legs, your foot. Bear with me. I'm checking for the plantar reflex. What's the plantar reflex?
Outgoing.
I'm going. All right, thank you. So all right, thank you. So I'm going to check for how you can feel things now. So I'll start with this wool, cotton wool. So I'll put it in his chest. So this is the way you feel it. So when I put it in your legs, just tell me if you can feel it, okay? All right, so I'll start from the foot. Are you able to feel it? Can you feel that on both legs? Can you just tell me yes if you can feel it?
Yes, he didn't feel it.
He didn't. No, he can't. Or yes, he did.
He didn't feel regarding the touch.
Okay, no, he can't feel it. Okay, so I'll keep going up. I'll go to L5, L4 on both sides. Can you feel it?
No.
No, we can't feel it. So I'll keep going up. All right, thank you. So I would do it downward as well. Then get my pen. This is a pen, it's a sharp. It's not going to hurt you. So I put it in your chest first. Okay, can you feel this? So I go down and then try to check for the sensation as well on the feet. Can you feel that?
No, he didn't feel.
All right, thank you. So I'll take my tuning fork. I also want to check how you feel this as well. So I'll put it on his chest first. This is the way you feel it. So if you feel it on your legs, do let me know. Okay, all right. So I put it on the big toe first. Can you feel it?
No.
No. All right, good. So I'll put it on both feet and I go up.
1 minute left.
I'll go to the ankle and then I'll go to the tibia tuberosity. Can you feel it?
No, doctor.
All right, thank you. So all right, can you use your leg, the shin of the heel of your leg, roll down the shin of the opposite leg? Can you do that for me?
He didn't able.
He's not able to do that. All right,
The
thank
coordination
you.
intact, yeah.
Coordination intact or not intact? Is it intact?
Intact.
Intact.
Yes.
All right, thank you. So are you able to walk for me, Mr. Ali? Are you able to walk for me? And do you want me to give you your walking aids to see how you walk?
Yes.
All right. So how is the gait like?
Yes, scissoring gait.
Scissoring gait.
Yes.
All right, thank you. So I'll look at the back. Is there any swelling at the back? All right, thank you. Can you tandem? Can you walk on a straight line for me? Are you able to do that? I know it might be difficult. Don't worry, I'll support you. Okay, and also, can you put your legs together? I will support you and close your eyes and see, checking for lumbar test. Is it swinging to any side?
No.
No, all right.
Negative.
Negative. Thank you for allowing me to examine you today, Mr. Ali.
Okay.
You can cover up. Thank you.
Thank you. Well
Thank
done.
you.
Yeah, question, Dr. Sarah, please.
Yes, could you please present your finding for me for this patient?
All right. I just examined this gentleman who has evidence of spastic paraparesis as evidenced by the external rotation of the legs, wasting of the muscles, as well as hypertonia and hyperreflexia. The plantar reflex is upward going. So I'm suspecting that this might have is having a spastic paraparesis, and the possible causes of this could be depending on the presentation for this patient. Because of the muscle weakness, I'm concerned that this might be a chronic ongoing thing. So I will possibly consider the possibility of cerebral palsy in this patient. I will also want to consider I also want to consider a possibility of anterior spinal artery infarction, parasagittal meningioma in him, and also hereditary motor sensory neuropathy as well could be a possibility. But I will want to further do further examination, such as check his upper limb, cranial nerve assessment, and also take a further history to be able to narrow down my differentials. Thank you.
Okay. So what is your workup for this patient?
My workup for this patient would include doing a MRI brain of the spine and the spine, looking for any form of cord compression, also any tumor in the brain or in the spinal cord. Then I will also want to do electromyography and also nerve conduction study, looking for evidence of demyelination or axonal affectation. Then other investigation I want to do will include full blood count, to include vitamin B12, folic acid, do inflammatory markers.
Why vitamin B12 in this patient?
I want to do vitamin B12 because possibility of a subarachnoid combined generation of the cord is a possibility here. But however, I will expect more. I will expect that it should have a dissociatory sensation abnormality. But in the later phase of subarachnoid combined generation of the cord, they can also have affectation of all the sensory affectation as found in this patient. Then other possibility I want to do could include paraneoplastic screening as well.
Dr. Please, regarding these patients, you mentioned that your patient, he has spastic paraparesis. What about the sensation?
The sensation is also down.
Did you consider anything in your differential diagnosis for this patient?
Yes, I consider that. That's why I consider the possibility of hereditary sensory motor neuropathy in him.
What regarding the sensation in this patient? Is it intact? Is it impaired?
It's impaired.
Okay, so which sensation it affected in these patients?
What sensation?
Yes.
The pain is affected.
It is anterior, is it posterior, dorsal? What exactly?
Both the anterior and dorsal. The pain
in
sensation
such a case, yeah,
is affected in him.
Okay. So in such cases, you mentioned that your patient, he has spastic paraparesis with complete cord infections. So what
Okay.
is your differential diagnosis for this patient now?
I would think of a possibly cord compression.
Mhm.
Then I'll also think of a possibility of a subarachnoid combination of the cord for
The
him.
subacute combined degeneration,
Then hereditary spastic paraparesis could also be a cause here.
subacute combined degeneration can come like this presentation. Okay, so what is your plan of management for this patient, doctor?
Oh, my plan would be the management of this patient in terms of management would be multidisciplinary, and that will include the neurologist, the physiotherapist, occupational therapist, the physiotherapist as well in his management, and then I would want to consider physiotherapy to organize appropriate exercise for him that will help with his mobility, and then occupational therapy to supply him with to make some adjustment to his day-to-day activity, like providing with walking aids, make adjustment to his home. Then the also because of his spasticity, he might benefit from some antispastic medication like baclofen could also
Okay.
help in this with this. Then could also help in its management. Then patient counseling and education to would also the support group as well will be important, as well as continuous follow up in the clinic.
Okay, so doctor, when you are examining this patient, you find that he has wasting. Could you explain for me
Yeah,
the wasting in this patient?
the wasting might be this disuse atrophy. Can be this disuse atrophy, and also possibly because of the disuse atrophy.
Okay. Okay, so okay, thank you, doctor.
Okay, I will add question for Dr. Ayala. Since you are having sensory loss for both superficial and deep, what specific image you want to add?
Imaging.
Yeah.
Okay, possibly. Okay. I'm not quite sure. I know I would do MRI spine and the
Yes, the
brain.
MRI for the cord.
Yeah,
Right?
brain and spine. Yeah, that was the first thing I mentioned. So I thought there was something else you were expecting.
She mentioned it, yeah.
But she mentioned as general. She didn't,
Yes,
and she was talking about spastic paraparesis without sensory affection.
yeah,
She
yes.
was saying as this is the differential of, and the MRI she mentioned was like in general. Now I specify the image for spastic paraparesis with sensory affection. So the MRI will be the target image of choice, right?
Yes.
Okay, thank you, Dr. Ayala. Well done. Let's hear Dr. Sarah comment, please.
Yes, regarding her examination, she did well, apart from the sensation. When you are fine, sensation is deficient or loss. We need to follow and going up, up, up until we reach the level of sensation for this patient. Inform the level of sensation didn't ask me at which level you feel, okay? And also when you are reach it, yes, you should ask if like above, okay? So in the presentations, regarding the presentations, just the deficiency in presentation, you didn't present all the finding in your case. Just should mention like this on examination of this patient, there is walking aid beside him, and when I examine his lower limb, he has wasting, okay, and he has external rotations of his feet, which indicate bilateral foot drop, okay, and he has got sign of upper motor neuron lesion in the form of hypertonia, hyperreflexia, okay, and going plantars, okay, positive colonus, and the weakness, which is pyramidal shape of weakness. Because the pyramidal shape of weakness in these patients, I will give you regarding the flexure is more weaker than extensor in the thigh muscles. Also, I will inspect from you to check for the abductor and abductor muscles, okay? And also, regarding the sensation is totally deficient, or four modalities of sensations for anterior cord and the posterior cord for this patient. Anterior cord, which is the touch and the pain, and also for posterior cord, which is vibration and position sensation loss. At which level? This is the most important to determine this patient he has sensory level. Okay. Regarding when you are conclude your finding, spastic paraparesis with complete cord infections. So for differential diagnosis. Also, you can mention, I would like to complete my examination by examining the back of the patients if there is any trauma and deformity, because the trauma in differential diagnosis for this patient, okay? And also you can mention the upper neurological examination, like upper limb and other. The gait, yes, you find that the gait is scissoring gait or spastic gait. And also regarding the differential diagnosis for these patients, just trauma to the back, and also you can beat any tumor, tuberculosis, and yes, transverse myelitis also. Okay. Regarding the investigation, the most apart from the general workup, the most important investigation is MRI spine. Okay. After that, the management for this patient, yes, non-pharmacological education counseling, MDT, including all including physiotherapist, neurologist, occupational therapist, and treat underlying cause and treat the complications. Complication, yes, you mentioned spasticity. You can give aclofen. If this patient has neuropathic pain, you can give him pregabalin, amitriptyline, and like this. Okay, gabapentin. So regarding the wasting, yes, occupational therapist, yes, I mentioned. Regarding the wasting, yes, because of disuse atrophy, this patient has long-standing weakness. And also, it might be associated with neuropathy if the examiner tell you anything else. Okay, that is all for this patient. Thank you.
Yeah, thank you, Dr. Sarah. Well done. Good preparation and good case as well. Dr. Ayula did well with good performance while examining, but when she present, I think she was lost. Why? Because she didn't check for the sensory level. She did examine the sensation, but she didn't go up with the sensation to know at what level this patient is losing his sensation. So I will ask Dr. Sarah now, what level or what the sensory level of this patient?
Yes, as up to the diaphragm joint.
What joint? Iliosacral?
No, diaphragm joint.
Again, which joint? Up more in the chest, you mean?
No, up to the diaphragm joint.
Xiphosternum, okay.
Episternum joint.
Mm.
Is that
Yeah,
what you
okay.
mean?
I think this is T10, right? Sternum.
Yes.
T10.
T8.
Thoracic T8. Okay.
Umbilicus T10.
Yeah, umbilicus T10. Yes. Okay. Okay. Well done. Again. So why Dr. Ayula lost? Because you didn't examine the level of the sensation. You give differential, by the way, you give the differential of spastic
Mix it.
paraparesis.
Yes.
Yeah, without sensory
Sometimes.
affection, which
Yes.
is
Yes.
cerebral palsy, parasagittal meningioma, tropical and hereditary spastic paraparesis,
Mm.
which are the differential of spastic paraparesis without sensory level. Whenever you have sensation affection, you have to go up with it to reach what level is lost. And you will never give upper than the level of this lesion. What I mean, if you have sensor level to the T, for example, at the same scenario, so you will mention all the cord affection. You will not mention anything in the brain. Okay? As well as, or as long as the sensation is lost at a sensory level. So let's talk about the causes of sensory level with spastic paraparesis. Mostly complete cord dissection. In our scenario, either trauma or transverse myelitis or TB or tumor or cancer, even METs can be the reason. Why? Because you lost the whole sensation below this level. So it's like complete cord dissection. Trauma, mostly you have to examine the back. I like when you said I want to examine his back, but you didn't mention why. Why you might have a scar either for tumor excision or trauma. He might have trauma with fracture. So you have to complete your examination by examining the back. Clear? Yeah, otherwise the manifestation typical of upper motor neuron lesion in the form of always present like this. I have features suggestive of upper motor neuron lesion in the form of hypertonia, tone, the power, reduced power all over because of the spasm or spastic muscle. So the tone is hyper and the power is reduced globally and the reflexes is exaggerated. Hypertonia, hyperreflexia, reduced power. The coordination was intact, or in this scenario, I guess it will not be intact because there is no posterior core or there is no sensation in the dorsal column, the deep sensation. So how he can do the coordination? Or is it related to cerebellar, Dr. Sarah? Right? Anyway, he
What?
doesn't have any sensation here to do the coordination peripherally because you said the coordination is intact,
Yes.
but he cannot do because of the spasm or the weakness.
Yes.
He will not be able to do. Okay, so the coordination you will mention.
Just he do it because he can walk.
Okay, so he can do it.
Yeah.
But I think because of the intact cerebellum, he can do it. But the deep
Yes.
joint, the deep sensation is lost.
Yes.
Okay, back to the presentation. So features suggestive of upper motor neuron lesion in the form of hypertonia, hyperreflexia, global weakness because of the muscle spasm or the spastic muscle. The coordination he couldn't do or he will do according to the patient due to the weakness. And the sensation before mentioning the sensation in this scenario was totally lost in the form of deep and superficial. By the way, if you don't have time to do both sensation tests, do at least one for everyone. So for the superficial, at least you will do pain prick or the cotton sensation or soft sensation. If one of them is lost, you can do the deep sensation, either the joint or the tone, the vibration. And whenever you have lost sensation, please go up in comparison first, and then to detect the level of the lesion or the sensory level. If you discover it, you can mention while presenting, I have sensory loss to the level of, for example, T11 or T10, umbilicus, or xiphisternum in this scenario to T8. Okay, back to the presentation. Continue this sensation and the gait. The gait was, in this scenario, scissoring gait, and Romberg test was what you mentioned, Dr. Ayula. You didn't mention the Romberg test. Is it lost or positive or negative? And what do you think? Dr. Ayula, what do you think the Romberg test in this scenario? You are muted.
I think she mentioned it. She said it was normal. She said it when doing her examination.
But I think it's negative. Sorry, it's positive. He lost the dorsal column, right? So he will fall if he closes his eyes. Right, Dr. Sarah? So Romberg test here will be positive, not normal.
Yeah, hello. Yeah, Robert, she said it was negative. It was not. It was negative, but I think it should be positive.
Yeah, exactly. It should be positive. As long as you have dorsal column affection, the patient will lose the sensation of the surrounding or the ground or the joint sensation. So whenever he will stand and close the eye, because he's maintaining the position, standing position with his eye opened. Whenever he close the eye, he will lose the sensation of the joint and the floor. That's why he will feel dizzy and he will fall down or he will fall down. Okay, so supposed to be positive Romberg test, not negative. As long as you have dorsal
Yes,
column affection.
positive, Dr. Batum. Yes, positive.
Yes, exactly. So any patient with dorsal column, he will fall down, and you have to say positive Romberg test. Okay. If he has cerebellar lesion or cerebellar affection, he will never stand up. He will fail, or he will fall even while he's opening his eyes. He will have attacks in gait. But this is the difference between the dorsal column and how to pick up the finding of dorsal column affection. You will do the Romberg test. Okay, back to the presentation. We finished the gait and Romberg test. Yeah, so my finding suggestive of spastic paraparesis with a sensory level. 2, the sensation affected, you have to mention to the deep and superficial sensation. So I have cord affection anterior, posterior, plus the weakness of the upper motor, the form of upper motor neuron lesion. So mostly I have the lesion mostly in the spine or at the level of spine in the spinal cord, right? So you will narrow your differential now to something or to lesion in the spinal cord at the level of spine, whatever the lesion, the level. Okay, what you have to do, I would like to take full history of trauma, tumor, or infection like transverse myelitis or TB. So I have to take full history from the patient, particularly the trauma one. Some examiner will ask you what else you want to examine. Always remember the trauma. So you will offer examining the back. The back will give you a clue if he has a scar. This patient might have scar at his, for example, teenager or adult age, and after this trauma, he had complete cord section or transection. Okay, this is the case about and the differential. Sorry about this case. The investigation. Of course, you have to start by the routine investigation, specific investigation. You can add some vitamins. By the way, subacute combined degeneration. Yes, you can mention it if there is asymmetry and you have different sensation affection, like posterior column affected rather than being anterior cord. Usually it affects the dorsal column. So you might have posterior colon affection, yes, upper motor neuron lesion, and you might have, I think, cerebellar, right? Cerebellar affected in the subacute combined, or it would be spared. No, cerebellum will not be affected. Yes, different. The Friedreich ataxia will be affecting the cerebellum. Okay, so you cannot put it as a differential here because you have anterior and posterior cables and sensation affection. Back to the image. So the image will be target, or the image of choice will be MRI spine. You will find the lesion, or you will find, for example, the TB or the mass, tumor. Always remember 3T: trauma, tumor, and TB, and transverse myelitis as well. Okay. The management plan, of course, you have to mention the physiotherapy, non-pharmacological multidisciplinary team approach, occupational therapist and physiotherapist for the limb physiotherapy to release this spastic muscle, and occupational therapist to support him with wheelchair or some walking aid if he needs. Baclofen as muscle laxant, but I think it's something to be living with as lifelong. Because the lesion already happened, and the trauma or whatever the reason happened is something irreversible. If you have sensory intact or preserved sensation, so you will talk about the differential of spastic paraparesis without sensory level, which are parasagittal meningioma, cerebral palsy, hereditary and tropical spastic paraparesis. Okay, clear for all now, this case? It's a good case, by the way, you can get it easily. But don't forget to mention and to examine the sensory level. This is the clue of the case. How to detect the level of the lesion of the spine affection? What I mean, if you want to locate the lesion of the vertebrae, how to locate it? Anyone know the equation? Dr. Sarah or Dr. Ayula, you know?
Yes,
Dr.
what
Ayula?
Mr. Basim? I'm sorry.
Okay.
How
Little
to
bit busy.
locate the lesion of vertebra? I mean, if you have sensory level to the level of C7 or C8, how to
Yes,
examine the vertebra? At what level?
below the level.
How many?
If C7 or
Yes.
C8, it will be C6.
So you will
If C8,
minus 1 or 2?
2.
Exactly. Okay. You know the equation from C1 to C6? How much you will minus?
From what? From where?
From C1, cervical 1 to cervical 6.
Minus 1 or 2?
Exactly. Yeah,
Minus
minus 1. From C6
Yes.
to C12, you will minus
2.
2.
From what? Yes,
Yes,
2.
2. And thoracic?
2.
At the thoracic level, you will minus?
At the same level.
No, it's 3, minus 3.
Okay, thoracic. Okay, yes.
Okay, thoracic. So cervical 1 to 6, you will minus 1. Cervical 6 to 12, you will minus 2. All thoracic, you will minus 3.
Okay.
So if you have dermatome affection of T8 at the same patient here, you will examine at the
T6.
level of Exactly, T6.
Yes, yes.
T6, yes. Sorry, not T,
T5.
T5. Yes, T5.
Yes.
Okay, clear now for all this equation?
Please,
you're
Dr.
not-
Benson, come again. Sorry, I didn't get you. You said what?
Okay. You want to locate the lesion of the vertebrae. At this lesion, the cord is affected. Okay? How to locate the lesion of the spinal cord at the vertebral column? Because the vertebral column is longer than the spinal cord, right? Because the spinal cord located inside the vertebral column. You will not have the same level of the vertebrae at the same level of the nerve root, right? So how to locate it? You have to minus in the cervical lesion. From C1 to C6, you will minus 1. So whenever you have lesion at the level of dermatome C7 or C8, for example, when you examine the neck, you will examine at the level of C6. If you have C7, sorry, if you have C8, you will examine at the level of C6. You will minus 2. You got it, Dr. Henry?
Yes, yes.
From C1 to C7 to C6, you will examine level above. So if you suspect a lesion in the C6, like in the thumb, right? The thumb dermatome is C6. When you will examine the vertebral level, you will examine at C5.
Okay.
Got it?
Yeah.
So you will have the lesion or you have a scar at C5. And the dermatome affected was C6. But you will have the scar at the level of C5. The same as the thoracic. In our patient is having sensory level at T8. If you want to examine, you will count from up down to the level of vertebrae vertebrae T5. You will have the scar at the T5.
Okay.
You got it?
Yeah.
Okay. Any other question? Dr. Sarah and Dr. Ayula, any question?
No, thank you, doctor.
Any question, Dr. Ayula?
No, thank you.
Okay. Any point or discussion from others? Anyone want to add?
Dr.
Henry?
Bassel,
Yes, Dr. Huda.
cervical spondylitis, one of the
Yes.
differential diagnoses.
Cervical, if you have now the lesion at the thoracic area, you cannot say this is cervical, right?
Because of the sensory level.
Yes, exactly. If you have sensory level to the C, for example, 3 or 4, yes, you can add it.
Okay. Okay. Sorry, the equation of the vertebral level from 1 to 6, I minus 2 or 1.
From 1 to 6, you will minus 1. From
Okay.
C6 to C12, you will minus 2.
2.
Yes. And the old thoracic, you will minus 3.
Okay. Thank you very much.
Most welcome. By the way, Dr. Al-Huda, cervical, something confined to the cervical, so you cannot mention it as a thoracic. Something happened only in the cervical. It's related only to the cervical vertebrae and cervical lesion. It's medical cause, you know?
Yes,
So
doctor.
so you cannot say it in the thoracic. It's nothing called thoracic spondylolysis. It's mainly in the cervical.
Okay.
Okay, and according to the level, you can give differential, but it can be the differential if you have sensory affection in the upper limb, as well
Yes.
as weakness in the upper limb. Why? Because C5 and the cervical are supplying the nerves of the upper limbs. But in the lower limbs, you have to specify to the thoracic level. Okay. Yeah, sorry, I mentioned C12, it's C8, yes. The maximum number of cervical was C8, not C12. Nothing called C12. Okay, thank you, Dr. Rehab, for correction. Cervical end at CL10, yes, C8. The thoracic is the 12 number, yes, you're right. Sorry for this mistake. So from C1 to C6, and from C6 to C8, and from T1 to T12. These are the levels. Nothing called cervical 12. So we have 1, 2, 3, 4, 5, 6, 7, 8 cervical, and 12 thoracic. Yes, thank you for the correction, Dr. Fatma and Dr. Rehab.
I'm
Dr.
sorry.
Fatma.
Please,
Yes.
doctor, sorry, I lost you there when you were talking about the sensory levels. I got the ones that sensation not involved, which is cerebral palsy, cerebral meningioma, hereditary and tropical spastics, paraparesis. And then for the one that has sensory level, we have the T's, isn't it? Transverse myelitis, trauma, TB, tumor. What else, please? Because I don't know. My
Yeah,
reception was bad at that time.
yeah, the difference between both, the sensory level.
Yes.
If there is sensory level, you will mention the vertebral column affection.
Okay.
When you have intact sensation, you will talk about the parasagittal meningioma, cerebral palsy, and hereditary tropical spastic paraparesis.
Yeah.
Okay, you will not mention the cervical cord, the cord lesion at all.
I think
Okay.
in the hereditary and tropical, it is with sensory level.
No, I don't think. Who's asking?
Okay, I
Dr.
will check.
Rehab? Dr. Rehab?
Yeah.
Hereditary and tropical, from the name, it's spastic paraparesis without sensation. I remember it.
Mm-hmm.
Up to my knowledge, anyone can confirm, because there is no
Yes,
motor,
without
no
Yes,
sensation,
yes,
no
yes.
sensory level, and no
So,
sensory center affection. It's
Yes,
affecting only the motor power
mm-hmm.
yes, without sensory.
without sensation, yes.
But
Okay,
it's
Dr. Rehab.
affect the segment of the spinal cord. So the level down will be affected.
Mm-hmm.
It is not an upper lesion in the brain.
I remember all are differential together. Cerebral palsy and parasagittal meningioma and hereditary tropical
Multiple
spastic paraparesis.
sclerosis, amyotrophic lateral sclerosis. Yes,
What?
multiple sclerosis and
Multiple.
motor neuron disease
This
No,
is for
we are discussing about
this is
tropical and
without
hereditary spastic paraparesis.
yes,
without, you mean?
yes,
Yeah, but multiple sclerosis, you have another manifestation, right?
yes,
You mean no sensation affection, right?
yes, no sensation without
But it
sensory.
will affect the dorsal column. Multiple sclerosis affect the dorsal column.
Not
Right?
mandatory in any
Yeah,
presentation.
it's not common, but it affects.
Mm-hmm. I think multiple sclerosis is
Yeah,
not going to be
multiple
among
sclerosis
patients.
is likely affect the thick myelinated sheets, like the
Yeah.
dorsal column.
Yes.
Mm-hmm.
So you will have it with dorsal column differential, multiple sclerosis, but you cannot mention it in our case today.
No, not in our case.
Okay.
Without sensory, yeah.
Yeah, without sense.
So without sensory, it's going to be like MND with the upper motor neuron
Yes.
affected. Yeah.
Yes.
Yes.
Mm-hmm. Like the
I think
primary
multiple sclerosis can be both
sclerosis.
with or without sensory level, yes.
It's not commonly to be, but yeah, sometimes it might be affecting the sensation. Commonly the dorsal column.
Mm-hmm. Thank you.
Most welcome. Okay. Any other question? I think there is comments. Anyway, to put multiple sclerosis, yes, we'll discuss it. Sensory ataxia. Yeah, our case today, yes, he has sensory ataxia. So he has positive Romberg test. Spasticity, difficult coordination, exactly. Look for scar at the back. Dr. Henry, yes, we did. We talk about some spinal surgery are done in front. Okay. Yes, it's not mandatory to be, but you have to examine. Yeah, the sternum, T9, symphysis, xivosternal. Okay. Any other question before ending the session? Thank you, Dr. Sarah and Dr. Ayula. Well done and good session as usual.
Thank you,
Anyone
Dr.
with?
Basu.
Yeah, most welcome. Any other question before ending the session? Okay. Have a nice weekend. See you inshallah next week. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you, Dr. Basu. Good night.
Thank you, Dr. You're most welcome. Thank you.